Hello everyone, I'm Deepanshi and I'm a clinical attachee with Dr. Sain and I'll be doing this presentation on rare dementias and the incidents we have seen here at Luton Memory Clinic. And one of the main motives of this presentation is to not only improve the understanding and treatment of rare dementias, but for also for me to learn how quality improvement and audits are usually done in NHS. So let's begin with it. So in this, we will be covering the background on rare dementias, investigations, the treatment and the challenges faced, purpose of the audit, outcome, and future implications. Okay, sorry. So, what are rare dementias? Rare dementias are less common neurodegenerative disorders that affects both cognition and behavior of a patient. So, while they account only for 5 to 10% of dementia cases, they have a significant impact on the patients. Early diagnosis and tailored management are key to improving patients' quality of life. So, here are a few types of rare dementias. For first of all, young onset Alzheimer's disease. It usually occurs before the age of 65, and the symptoms are similar to the regular Alzheimer's, but they may progress a bit faster. Then comes the Lewy body dementia. It causes changes in attention. That means fluctuating cognition, visual hallucinations, Parkinsonism, and postural instability in a patient. It can often be confused with Parkinson's disease, but however, here the cognitive symptoms they precede the motor symptoms. Then comes Parkinson's disease dementia developing in patients with Parkinson's disease, and it usually occurs after the motor symptoms. It is characterized by memory issues, hallucinations, and depression. Then comes frontotemporal dementia, which affects mainly the frontal and temporal lobes, which leads to personality changes, disinhibition, and language difficulties. It has two variants, behavioral and primary progressive aphasia. Then comes more types of dementia which are comparatively rare. So primary progressive aphasia is a type of frontotemporal, but it is characterized primarily by language deficits, starting with trouble in speaking, and it progresses to severe language impairment. Posterior cortical atrophy, it is a visual processing disorder, sometimes referred to as visual Alzheimer's. Its early symptoms are difficulty with breathing, spatial orientation, and recognizing objects. Then comes progressive supranuclear palsy. It causes balance and movement problems along with difficulty controlling eye movements. It's often mistaken for Parkinson's disease, but it progresses more rapidly than that. Then comes corticobasal degeneration. It is a rare, but its symptoms include muscle rigidity, involuntary asymmetrical movements, and cognitive decline. Then comes Huntington's disease. It is a genetic disorder. It has a strong genetic history and it leads to motor dysfunction, psychiatric symptoms, and memory issues. And it affects individually, typically in their 30s and 40s, and it's a progressive kind of dementia. So diagnosing rare dementias, it requires a thorough clinical and neurological assessment. We use cognitive tests to assess a patient's memory, language, visual spatial functions, and solving skills. Neurological and neuropsychological tests are also done for patients who need them. Then comes imaging like MRI and CT scan, which can show atrophy patterns like frontal and temporal atrophy in frontotemporal dementia. Uh, FTG and PET scan, it also helps to identify areas of low brain activity like in frontotemporal versus Alzheimer's. It helps in distinguishing them. Then comes DAT scan, which is helpful in Lewy body and Parkinson's dementia. And also amyloid scan and tau scans, they are specific scans, but they are not that available here in NHS. Then comes biomarkers For example, CSF testing, which can help detect amyloid and tau levels, which are indicative of neurodegenerative disorders, and genetic testing, which is more relevant with hereditary forms like Huntington's disease. The most important thing is to rule out differential diagnosis, could be caused because of reversible causes like vitamin deficiency. For example, vitamin B3 niacin, its deficiency causes pellagra, which has dementia as one of its features, and the other causes may be infections or normal pressure hydrocephalus. Treatment and management. So there is no specific treatment which is available specifically for rare dementias, but symptomatic treatments are used. For example, cholinesterase inhibitors like donazepam, rivastigmine, they are useful in Lewy body and Parkinson's to improve the cognitive functions and to reduce hallucinations. And SSRIs are usually used to manage the mood and behavioral symptoms. We can also use antipsychotic medications and physiotherapy and speech and language therapy for patients with language difficulties. So basically, a multidisciplinary approach is uh, required, which involves neurologists, psychiatrists, psychologists, specialist nurses, occupational therapists, and social worker. So why are rare dementias often underdiagnosed? So rare dementias, they have overlapping of symptoms with more common forms of dementia like Alzheimer's, which can lead to misdiagnosis. And there is a lack of awareness as clinicians may be less familiar with rare forms of dementia, especially in setting with fewer specialized resources. And early signs like language difficulties or visual issues can be often attributed to other conditions. And they usually present with atypical features. So they have unusual symptoms like alien limb phenomena and CBD, which can lead to delay in diagnosis. So impact on clinical practice. So basically, delayed treatment and mismanagement of patients can cause issues with diagnosing the patient and giving them a specific treatment. And there is importance of multidisciplinary collaboration, which might not be done in place and the patient might be affected with it. So what is the audit? So the diagnostic challenges are the highlight and the need to improve recognition of rare dementias, which is the focus of our audit. So and this is an audit. For the audit, I reviewed all the patients seen by Dr. Sen and Dr. Kapila at Luton Memory Clinic from January 1st, 2024 to October 2024. As expected, the majority were diagnosed with common types of dementias, like 25% with Alzheimer's, 8% with vascular dementia, and 18% with mixed dementia. However, we also found that a few patients, like 7%, were diagnosed with functional cognitive disorder, 17 with mild cognitive impairment, but there were also around 27 patients out of 284, which which represented 9.5% of the total, which were diagnosed with dementias. However, there are a few patients which are under evaluation and there couldn't be made a diagnosis for them yet. And these the patients who were diagnosed with rare dementias are usually the one with frontotemporal or Lewy body and primary progressive aphasia and there's cerebral amyloid angiopathy and Parkinson's disease, dementia, and many more. So moving forward, this audit gives us several important takeaways. So to see whether we could identify the patients early when presented with atypical symptoms and to refer the patients for appropriate investigations, like I mentioned before, because the scans and the investigations, they play a major role in diagnosis of rare dementias because they are easily confused with the regular ones. And to refer the patients to for rare dementia support team to consider forming a local rare dementia support group and to upskill the knowledge of clinicians so that they might be able to find the patients with a rare dementia comparatively easier, and they might be able to diagnose someone with rare dementia early with their symptoms so that they could get the appropriate support when they need it. So that's all. Thank you so much. Any feedback?
So thank you, Deepanshi. It was a really good sort of presentation. Does anyone have any questions? I had a quick question. So you mentioned that Alzheimer's dementia and sort of vascular dementia, and you know, if anyone's an old age psychiatrist or a old age psychiatry registrar, that would be really helpful if they could sort of provide insight into this. But essentially, you mentioned that it just makes 5% of in terms of the prevalence. When I was working in old age, it was much more common than that. I was seeing a lot of people with Lewy body dementia.
Okay.
So I don't know what your views, you know, if anyone else has any other experience about that.
Sorry, Arthur, I'm just a bit confused. Did you say that you were saying what was the percentage of people you saw with Lewy body?
So Deepanshi in her sort of slide mentioned 5% for non Alzheimer's and vascular. But when I was working, I saw Lewy body quite often.
Really?
It wasn't that rare. I don't know, if I was thinking about it, it'd probably be like 10%.
Yeah, it's 9.5% of rare dementias, not
Oh,
5%.
oh, I see. Okay, sorry, I must have misread that.
Yeah.
Yeah, no, okay, that's fine. So Femi, just on another note, what's your
Yes.
views on lecanemab? You know, they talked about immunotherapies and things like that. Are they disease modifying, or are they kind of similar to cholinesterase inhibitors where they address the symptoms?
No, they're disease modifying.
Oh,
They're a bit more, just in
oh,
terms of their side effect profile, they're a
yeah.
bit more complex in that.
Uh-huh.
I think the main issue with them is they can cause cerebral bleeds.
Mm.
But they are disease modifying.
Okay, interesting.
Yeah.
And who would be kind of administering that? Would that be old age psychiatrist, or would that come under neurology?
It's not very clear yet, but I suspect it would be old age psychiatry.
Uh-huh.
I don't know how ready the NHS is for it at the moment, but it's definitely in the pipeline, and I think in another year or two, we expect that it will be, don't know if commonplace is the right word, but it will be prescribed in the UK.
Okay, interesting.
Yeah.
And it's licensed, right? Has it been licensed?
I think lecanemab has been licensed. I think lecanemab has, yes.
Okay, and it's just private at the moment. Is that
It's administered privately at the moment, yes.
Okay, excellent. That's really helpful. Thanks a lot, Femi.
Yeah, no worries.
So Femi is one of the old age psychiatry registrars. So, yeah. Any other questions?
And
I think Shushan has his hand raised.
there's just something just on that con with monoclonal antibodies for dementia, because incidentally, just like an hour ago, I just read this article because, I mean, there's been a subjective approval for lecanemab, donanemab for this, but just, I mean, it's a recent article from just day which says that the plans for bringing in monoclonal antibodies has been put on a back burner. So it's not cost effective. It's not, can see if I can find the link for that and send it over. But the latest we have on that is that the plans have been put on a hold with regards to having monoclonal antibodies.
Interesting. Yeah, Shushan, if you can share that, that would be great, please.
Sure. I think if I can just find it on the history on and also because the main stumbling block at the moment was about having the biomarker blood panels, the blood tests in place, because monitoring for monoclonal antibodies basically happens by looking for the amyloid protein, beta amyloid protein levels in the blood, and the dosage is going to be calculated. But having that as a mainline blood investigation on a general basis is still in its infancy, which which was sort of the stumbling block in actually having a full-fledged rollout. So just my 2 pence on it.
Yeah.
Thank you, Sushant.
Yeah,
That's
but
really
then, you can find the link. Yes, of course, I'll just put that in.
Femi, I had another question. I don't know whether you'll be able to sort of answer this, but in terms of DAT scans, when they talk about, because when I remember I found it quite hard for Parkinson's dementia and Lewy body dementia because the timeline is not always very clear. So how sort of sensitive is it and specific is it in terms of kind of differentiate, or does it even differentiate between Lewy body and Parkinson's?
I mean, I think the between Lewy body and Parkinson's, yeah, I'm not sure about this, but I think textbook doesn't it say that it does doesn't it say that it's useful, that the DAT scan is useful for distinguishing between Parkinson's pathology? I think it tells you that there is Parkinson's pathology, but I don't know if it differentiates between LBD and Parkinson's.
Yeah, because I think, yeah, because clinically I remember a lot of old age psychiatrists saying that. I think it's quite grey because I don't think I don't think it does, but when they do suspect, because they call it a spectrum, isn't it? Where they kind of say they're quite similar, but yeah, I remember that being thrown around quite a lot. If they suspected it, they'll just say, "Oh yeah, put them for a DAT scan." So I didn't know whether or not one.
Yeah, to be honest, I haven't. In my time, I've been memory service for about 9 months now, and haven't referred anyone for DAT scan. It's not something that we've done quite often. And just to go back to your question earlier, I have only seen one LBD in my time.
Okay.
Yeah. So yeah, I think these things tend to vary.
Can I add one thing?
Yeah.
Hello. Yeah, Dr. Malik.
Yeah. I think the scan does not help much to differentiate between the diagnosis, but it is mainly the clinical presentation. Lewy body dementia presents with quite a lot of visual hallucinations, and they are quite sensitive to psychotic medication. So that's one of the things. Clinically, you can differentiate. And also, any patient goes to neurologist, they will get diagnosed with Lewy body dementia. So that's another thing that you can see in the practice.
Yeah. Because I also think clinically, obviously, we differentiate them by the timeline. So if Parkinson's symptoms and cognitive impairment occur within 1 year, then it's likely to be LBD. Whereas if it happens so in Parkinson's dementia, they develop Parkinsonian symptoms, and then they develop cognitive impairment, usually after a year, then it's more likely to be Parkinson's disease.
Yes, along with the timeline. And sometimes the diagnosis changes quite a bit as well.
Yeah.
As the patient progresses. And yes, in some patients, there is clear-cut timeline difference. The patient will have a diagnosis of Parkinson's disease, and down the line, after 5 years or 10 years, they'll develop dementia. But sometimes, along with the timeline, clinical features also help to differentiate.
Yeah.
And as I said, whatever, if a patient goes to the neurologist, they would like to diagnose a patient with Lewy body dementia. Mostly that's whether it's Alzheimer's or Parkinson's. So that's their most common diagnosis you can encounter in the practice.
I think that's really helpful. Thank you very much for that. Dr. Femi and Dr. Malik for that, and Dr. Malik, really good presentation.